Minnie brought up the value of being involved in research for the persons who are in the research as subjects. But they are real heroes. They're the real heroes that make the research work. Without the subjects, there is no research. And for some of the disorders, as Mindy said, tremendous amount of effort, willpower, sacrifice has to go in to being a subject in trials. And the next session is going to talk about how do we make that opportunity, but not just opportunity, but the chance of a person with an illness giving back to the big effort to develop better treatments for that illness. How do we make that happen for more people, independent of where they live? We're certainly very restricted now to people in urban centers for much of what we do. And then there are big segments of our society that don't understand what we do, that never really are able to get involved in the research because of their socioeconomic status or their cultural biases. And that's something that here at NINDS and of course NIH, we're really focused on trying to improve, not just for the research, but as Neil said, we can break down some of these barriers in the research space. We can actually potentially improve the care of people. And there we want to improve the care for all people. And so the next session is going to talk about that. It's going to be moderated by Richard Benson, who's from our Office of Global Health and Health Disparities Research, and a great group of speakers. And I just want to say that Richard's been a fantastic member of NINDS, running this office through advanced health equity, worked through a strategic plan for us over the last over 2 years to develop a roadmap for doing this. Again, as Neil said, pointed out, we're working out against a broken system, but the research that we're trying to do is to work within the system. If we can't change it, work within the system to improve the outcomes for people who are otherwise really underserved in tough situations. So Richard, you want to start off? Good.
Yes, thank you, Walter. I'm going to ask all of our panelists to come front and to place your placard. Oh, there it is. Thank you. Yes. It's truly a pleasure to be with you this morning. And just like to say, Mindy, thank you for those really compelling and heartfelt comments and giving us a perspective of your lived experience. This is really important, and it makes us here at the NINDS understand why what we do is so important. So again, thank you for that. I really appreciated that. I'm going to first give a brief overview of what we are doing at the NINDS related to engaging rural populations. And then I'm going to introduce our speakers. I'm going to go through all the introductions, and then you all can come up in order to do your presentations. So as Walter mentioned, my name is Richard Benson. I'm not going to go through this slide. Walter talked about this already. But my office, the Office of Global Health and Health Disparities, what we do is we lead the coordination of and development and reporting on programs related to international and national issues related to disparities and inequities in neurological diseases. And these are all the people listed on the slide that actually do all the important work. And I can get up and do presentations like these. As Walter mentioned, the NINDS mission is to reduce the burden of neurological disease for all. And we highlight that all. That includes everyone here in the US and nationally as well. However, despite the mission of the NINDS, we know that there is a disproportionate burden of disease, neurological diseases for certain groups in our society. And so the NIH has designated certain populations as those that experience health disparities. And those include American Indians, Alaska Natives, Asian Americans, Blacks or African Americans, Hispanics or Latinos, Native Hawaiians and Pacific Islanders, sexual and gender minority populations, socioeconomically disadvantaged populations, underserved rural communities, and people living with disabilities. Today, we're going to highlight issues related to people in rural communities. Want to highlight as well that when you start to think in terms of the concept of intersectionality, when you think of people that have intersecting identities, for instance, a woman who's a sexual gender minority who lives in a rural community, the burden of disease is compounded because of those intersectional identities. So that's a group that we'd like to focus on in our office as well, including people with limited English proficiency. And so this is extremely important. And this was a concept that we thought about when we started our strategic planning for health equity, as Walter just mentioned. We used the Healthy People 2030 definition of health disparities and health equity. I'm just going to mention this briefly, just so that we know as you hear the presentations, we're thinking with the same definitions in mind. When we think in terms of health disparities, that's when you have a particular type of health difference that is closely linked to economic, social, or environmental disadvantage. And it disproportionately affects certain groups based upon some of those factors that we talked about in the previous slide. Health equity is defined as the attainment of the highest level of health for all people. And achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities and to address historical and contemporary injustices and the elimination of health and healthcare disparities. And so these were the definitions that we used when we started our strategic planning process for health equity at the NINDS. In August of 2023, the results of our strategic planning process was published together in a dedicated supplement of the Neurology Journal. It was dedicated specifically to our strategic planning process, and we had a total of 10 manuscripts published by our working group of our National Advisory Council. And they listed a number of recommendations, 18 high-level recommendations were presented to our National Advisory Council and approved. We've had those distilled into four through a AAAS fellow, Dr. Katie Reichart, who's here in the audience in our office. We had those recommendations distilled into four implementation strategies that we're going to use over the next 5 to 10 years to address health equity. One supports expanding support for health equity research, which is something that that we're working on, despite the budgetary concerns that Walter mentioned. The other is promoting engagement with the populations defined by the NIH to experience health disparities. And this came up earlier in one of the questions. And this is something that we're thinking about. We do have our first initiative where we looked specifically for projects that engaged one of those populations defined by the NIH to experience health disparities, along with a neurological condition and having a diverse team. Also developing a diverse health equity workforce and an increased health equity workforce in general, and then expanding in communication and outreach. And Penny sort of brought this up in her comment. I think it's important for the results that we have at the NIH, have them communicated to the public, the research community and the lay community as well, so that that information can be implemented properly and that some of the findings can be exported to other disease areas as well. And so these are the four pillars that we're working on to implement our strategic planning process for health equity. Additionally, and I think to the other question that was raised earlier in terms of the role of the NIH, as Walter mentioned, everything that we do at the NIH is related to research. However, we have created this, I don't know if you can see, if I had a pointer, I would point to the diagram. We've created the NINDS Social Determinants of Health Framework. And this shows those upstream factors beyond the individual that can relate to health inequities. And we'd like to highlight these for researchers as well as clinical care providers to think about all of those factors that can impact the outcome of individuals. And some of these, when you think of socioeconomic position or you think of housing or transportation, some of those the NIH does not have direct purview or control over. However, if we find, as Walter mentioned, through research that a particular intervention works to address those things, and those are things that we can do. We can provide the research foundation that can be used to enact policies to try to address some of these health inequities that we have there. So with that in mind, I have here some of the social media links for my office. We actually have a weekly listserv distribution where we send information, a newsletter out to people with up-to-date information. So please sign up for our listserv if you've not done that already. And so now, not to delay this any further, I'm going to introduce our panelists for today. We have Dr. Raquel Quarles. Dr. Quarles is a behavioral scientist and an associate professor of community health and preventive medicine at the Morehouse School of Medicine, with an adjunct appointment in the Department of Behavioral Sciences and Health Education and the Rollins School of Public Health at Emory University. She is also the associate director of the Morehouse School of Medicine Cardiovascular Research Institute, overseeing population science research. And she's going to talk about community engagement with rural and minoritized populations. Then we're going to hear from Dr. Suma Babu. Dr. Babu is an assistant professor of neurology at Harvard Medical School and serves as with the neuromuscular faculty there. She provides clinical care for people with ALS and other motor neuron diseases at the multidisciplinary ALS clinic at the Healy Center for ALS. In addition to this, she provides care for people with neuromuscular disorders at Mass General. And lastly, we're going to hear from Dr. Astrid Suki Dicey. She's going to talk about examining dementia in American Indians, lessons from the Strong Heart Study. I didn't mention Dr. Babu is going to talk about promoting ALS care access, a hub and spoke model proposed in a recent National Academy's consensus report titled Living with ALS. And she's going to present that today. But Dr. Astrid Suki Dicey is an epidemiologist focused on health disparities in neurodegenerative disorders, and she's an assistant professor at the Elson S. Floyd College of Medicine and the Initiative for Research and Education for Advanced Community Health, or IREACH. She's also the Washington State University co-lead for their Data Management and Statistics Core. So we'll start with Dr. Quarles.
Good morning, everyone. I am honored to be here to speak about the research that I have been doing as a community engaged behavioral scientist. My work has me partnering with community organizations, community members to do the type of research that I do. So before I start though, I want to get a sense of who is in the audience. So of those that are here who are part of or lead nonprofit community-based organizations, how many of you have partnered with an academic institution to do research, by a show of hands? Many of you, okay. And then of those, how many of you have led research studies? Thank you. I asked that question because I think that the work and the insight from community members, community based organizations, community leaders is so important. And so I start off oftentimes by answering the question, why do I do community engaged research? It's certainly not easier, but why do I do it? And quite frankly, there is no better way to do research, in my opinion. Getting the insight from community members can improve the science, can influence the research questions that I ask or that my colleagues can ask, makes our research more relevant to the population that we are focused on, and can accelerate the translation of research from discovery to application. And so I'm sure that many of you have heard of this 17-year odyssey, and in terms of the amount of time it takes from scientific discoveries to make it to community and put into practice in clinical care. And so the real question is, how do we shorten this in order to get the work get to the community members and improve the health outcomes of our community members? And so one of the ways that we at Morehouse School of Medicine are doing this is through what we're calling TX scholarship. So many of you have heard of translational research, and it's usually thought of as T1 through T4. We've coined this term of TX, recognizing that it's not always linear, and that it is not, it's oftentimes iterative and circular. And so in the way we do TX scholarship, we do it by having these multidisciplinary teams that include basic scientists, clinical researchers, health policy researchers, health services or health science researchers, as well as community engaged researchers and community members. Having everyone at the table makes it more likely that the research can get done, that it's more likely that the goals will be accomplished, and that the research results that we get are more applicable and can be better adapted and adopted in other communities. And so one quote that I really think speaks to the type of research that I do is, if you have come here to help me, you are wasting your time. But if you have come because your liberation is bound with mine, then let us work together. This quote, I think, is important because I'm not going into a community to be the savior. It's important that we are working together. I come with my expertise, but the community are experts as well. And so recognizing that in order for us to be successful in the work that we want to do and to improve the health outcomes of our community, then we are all needed at the table to do this work. And so I just wanted to take a minute so I'm a teacher. I teach community engagement. And so I just wanted to kind of give this spectrum of research that exists. So this image depicts that there is this continuum of community engaged research. Not all research involves community members, and not all research has community members. Not all research has community members. Their level of engagement may differ depending on the type of research that you're doing. But what we have to make sure that we are always taking into account are those equity indicators and those contextual factors. We have to recognize that when you are working in a community, that there is history there, perhaps negative history, mistrust with your institution, although you may not have been there at the time. But then also have to deal with the equity in terms of the power and control. Who's deciding the research questions? Who's deciding how this research is going to be implemented? And is the research mutually beneficial? Is it not just benefiting the academic, but is it also benefiting that community partner? And so taking these things into account is is, I think, essential in order to successfully do community engaged research. And I want to highlight community-based participatory research in particular, because that's something that I know that the other panelists are going to talk about in their research. And so recognizing that community-based participatory research is one that is, it's an approach, it's not a design, it's a collaborative process, and importantly, it has the researchers and the community represented in all phases of the research, which means that the community has a say in what the research question is, how the data is going to be collected, how the data is going to be interpreted, and then how is it going to be disseminated? How are the findings going to be disseminated? Only publishing our findings in scientific journals doesn't necessarily help the community. Community doesn't have access to the scientific journals. So having the community partner on board at all phases of it is important, so that we can make sure that we are disseminating our findings, our knowledge to everyone. And then also embodying this deep commitment to cultural humility, recognizing that we can never be completely competent in someone else's culture, but we have a lifelong goal of learning about that other culture. CBPR, of course, is always ethical and recognizing and responding to that the history of exploitation in some communities, as well as empowering those communities, or recognizing the power that those communities have within them. And so I just want to briefly talk about one of our projects, and which I think demonstrates how we choose to do the work that we are doing. Our Project Peach was a COVID-19, research study that was focused on COVID risk testing among people whose lives are affected by diabetes. And so we know that this affected many of the Black and Latino communities. And so those were our priority populations. And the way that we chose to do this research is we not only had research investigators, but we also had community investigators at the table. What we found out during COVID, the pandemic, is the challenges of getting into communities and being that trusted voice. Is the challenge was real, and having trusted voices on the team who can guide the way that we are approaching the work that we were doing was important. In addition to the community investigators, we also partnered with community organizations. So we partnered with community health centers or federally qualified health centers that were across the state, particularly in rural populations, because they were the ones that were closely connected to the community. They were the ones that the community trusted and who were providing the testing and then the vaccines. And so making sure that who we partnered with, and we were really intentional in who we were partnering with, and that the investigators were leaders across the state. They represented different organization types, and we had a history of working with them. The partners, on the other hand, were also geographically dispersed across the state. They had different organization types. So we included the community health centers. We also included faith-based organizations, as well as community-based organizations. And many of them we had a history of working with. And so the project, while we were successful in accessing and doing the work with 5,000 people across the state of Georgia, which was great. That's not actually what I want to talk about. I want to talk about where we went back and talked to our community partners and the investigators to learn what did we do well, what didn't we do well. And so from that, those interviews that we did, what we did was we interviewed every partner and every investigator. The academics, we analyzed the data and then worked with the partners to interpret the data and determine the themes that we found. The successes of our partnership were that the trust and rapport was really important. The partners, what we heard was that they felt heard and that their input was valued. That's what kept them at the table with us. Trustworthiness, that Morehouse School of Medicine has a reputation in the community of being trustworthy. And that was why they were willing to work with us. And then funding, surprisingly, while we always make sure that we are, if we're getting money to do the work, then our community partners should be getting money as well. And surprisingly, actually it's not surprising, funding wasn't always the reason behind them working with us. Many of them said, we would have done the work without, because they were concerned about their community and they wanted to make sure that their community got the latest information as soon as possible. And so that was one of the successes. And our challenges, of course, during the pandemic, there were plenty of challenges. But in terms of communication, you know, we all switched over to Zoom fairly quickly. And those communication tools that we were employing weren't known to our community partners. And so there was a bit of a learning curve for our community partners to be able to use these new tools. Then in academia, we're okay with meeting all the time, every week, especially now. And our community partners were not fine with that. And so we had to adjust. And so instead of meeting bi-weekly, we changed our meetings to meeting monthly. And every other month, we only did a 15-minute check-in, because recognizing that our partners were doing a lot in the community and they don't have time to be sitting on a meeting with us chatting about the work that they should be already out there doing. The other piece that we learned was that our investigators weren't always clear on their role. And so that's something that going forward, we have to make sure that we do a better job of communicating that role. And then lastly, recognizing that they had competing priorities. You know, with the community health centers, they are already operating on thin margins. They are, then they were trying to do testing, and then they had to roll out vaccines, and they're still trying to see their patients. And so recognizing that there are competing priorities, it was our job to be flexible in how we can work together. And having that rapport, though, made it so that they didn't just walk away, that they said, here's what I can do. And that was really the question: how can we work together? What works for you and what works for us? And so we were able to maintain our partners. We only lost one. We did lose one. And that was a new partner that we had never worked with before. And so going forward, we've been able to roll our partnerships into additional new projects so they're still willing to work with us, which I do appreciate. And so with that, I'm going to end. My time is up. Thank you. I thank, of course, my team, my partners that I work with, and our participants that have shared their info in order for us to do the work that we do. Thank you.
Morning, everyone. I'd like to thank the NINDS for giving us the opportunity to discuss some of the recommendations from the National Academies of Medicine report that was launched last month called Living with ALS. In particular, for this talk, I'm going to focus on 3 recommendations that have a direct impact on improving the access to both research and care, and also focus on community engagement in those remote rural areas, and which is a theme for today's panel as such. And Mindy, thank you for a great keynote this morning, and it's been an honor and wonderful to work with you on the National Academies Committee as well. So as you can see, the statement of task for the National Academies of Medicine ALS Committee was quite broad, focusing on ALS in terms of livability, care, research, quality of life, prevention. And this is an easy task to do, right? And to try to make ALS livable within the next decade. So it was a broad task, and the committee really came together with a number of really big challenges to tackle. And this was the 18-member committee that Mindy had earlier mentioned about. And each one of them on this committee has really been a great source of inspiration for me. The committee was chaired by Dr. Alan Leshner, who was the former director of the National Institute of Drug Abuse. I also learned that during his directorship, this very building where we are today was actually built and launched, which as a side anecdote. And we had interdisciplinary members from various different fields that contributed to this committee. So before we talk about the recommendations, let me take a step back and give you the context of multidisciplinary care in ALS as such. Multidisciplinary care is the gold standard in terms of the quality of care that is provided to ALS individuals and their families. You can think about multidisciplinary care as a one-stop shop where an individual with ALS or the caregiver will go into a clinic and they meet with multiple clinicians on the same day, including a neurologist, a physiatrist, or physical therapist, occupational therapist. Depending on the clinic's composition, it could really vary, a respiratory therapist, so on and so forth. Each visit for an ALS individual at the multidisciplinary center can last anywhere between 4 to 5 hours. That's one day of 4 to 5 hours of visit, meeting with multiple different clinicians. And depending on the need of care, an individual with ALS may see the team once in 3 months or once in 4 months. And in some cases, if they have a really rapidly progressing disease, they may even need to be seen on a monthly basis. So this is a format that has been in practice for many, many years in the ALS space. And many studies have shown that multidisciplinary care can improve outcomes, improve survival, quality of life, and also increases research access, because many of these multidisciplinary centers also function as research centers as well. Now, if everything is so great about this, there should be no problem, right? But there are several gaps in this. And this is just a small list of many gaps that are existing in terms of access and engagement to multidisciplinary care, as well as what's tied very closely to that is research, participation, and engagement. So we have, let's say that we have around 30,000 individuals living with ALS. That's the latest prevalence report that we know in the United States. But the number of multidisciplinary centers that are available in the US is only around 200. And that's not enough to care for all individuals living with ALS. And then what we've also learned is that nearly half of these individuals actually may live more than 50 miles from a multidisciplinary center. And about a quarter of them may live more than 100 miles from a multidisciplinary care center. And this is also sort of published data. And what we also know is that the average time for an ALS individual to be seen at a multidisciplinary center could be around 19 months. To provide context, post-diagnosis survival for ALS is about 2 to 5 years. So there are big gaps in this. And then the ALS Association estimates that only 40% of all ALS individuals are ever seen at a multidisciplinary center. We don't have, this is the tip of the iceberg, we don't have statistics on how many of these individuals who are actually seen at multidisciplinary centers will continue to be seen regularly and continuously throughout their illness course, and how many of these individuals may be seen at a multidisciplinary center once or twice before they sort of fall off the radar because they no longer can travel all the way to a multidisciplinary center. So, and less than 10% of all ALS individuals participate in research. We heard earlier in Mindy's talk to say that it's not about individuals not wanting to participate in research. There are many layers to this, including not having the opportunities to participate in this. And then the bigger issue is we're living in two different worlds that are siloed. This is the clinical world, and this is the research world. And as long as they remain sort of separate, we're not going to increase participation in research or accelerate research. We have to sort of integrate the two together and make research as an extension of care. And so all these delays also have lost research opportunities for many individuals, going from the time to diagnosis and then initiating care and so on and so forth. I'm sure there are other disease interest groups in the room today that are thinking, this is true about our disease of interest too. This is not about ALS alone. And this is a short list of other conditions where multidisciplinary care is recommended or at least thought of to be beneficial. It's not just ALS alone. So can we come up with a system that leverages all the same commonalities in terms of expertise and then merge the world of care and research together and help all diseases, not just ALS alone? And that's where this recommendation comes from the National Academy's report. Recommendation 441 really calls out on the National Institute of the Neurology Institute at the NIH, in addition to CMS and multidisciplinary care leaders, including the ALS Association, Muscular Dystrophy Association, the VA, and community-based providers to build an inclusive and integrated system that combines both the worlds of care and research for people living with ALS. And this is a cartoon of what this would look like. And we'll talk about each of these levels in this new reimagined care system. As you can see in the cartoon, people with ALS are really at the front and center of this new reimagined system. And people with ALS are connected to all the different care types that are imagined in this new visionary model, hub and spokes model of care and research. First is the community-based health centers. Community-based health centers are at sort of at the grassroots level, where these are local ALS centers. These are multidisciplinary centers where high quality multidisciplinary care can be provided to ALS individuals. And these are centers, all three types of centers in the reimagined system we envision would be designated by the NINDS. Designation of NINDS will not only incentivize these centers to be formed and scaled up and sustained, but also ensures that certain quality metrics are met, having those accreditation requirements in terms of not only care, but also research, but also to bring many more centers into the umbrella of care and research system that are not currently existing, and going beyond ALS into multiple neurological disorders. So community-based centers, when you focus on this, the idea is this forms the core of the new reimagined system. The idea is to really bring high quality multidisciplinary care close to patients' homes, even if they're living in remote areas or rural areas. This is one way to really tackle the challenge of access and continued care, even beyond the time point in their illness journey where they can no longer travel to a multidisciplinary center. And this is sort of, you can think about these centers as centers where they would get their routine post-diagnosis multidisciplinary care. And there are many different types of models for these community-based multidisciplinary centers. One such type is already existing in the ALS fields, and these are the ALS Association or Muscular Dystrophy Association affiliate ALS clinics. But the idea of this recommendation is to bring in many more of these multidisciplinary centers into the umbrella that are not currently existing and that are not specifically ALS, that are not ALS specific as such. For example, there could be multidisciplinary centers that are catering to a different disease population. Could be muscular dystrophies, could be Huntington's, could be MS, could be Alzheimer's, that may have almost the same composition as an ALS multidisciplinary center, a neurologist, physical therapist, speech therapist, dietitian, social worker, and they're all trained in very similar fields. So why can't we leverage that system and then give them accreditation and designation for ALS, train them on ALS outcomes and metrics in terms of routine monitoring of care, and then bring them under the umbrella, but it's still connected to hubs or those comprehensive ALS centers where everybody can get high quality care. Another such model is the integrated care network pods, and this is a recognized model within the CMMI, the Center for Medicare and Medicaid Innovations, where let's think of a rural community where there are several clinicians who are practicing independently, a neurologist, same, physical therapist, pulmonologist, so on and so forth. They're all practicing independently, but if we incentivize them to come together and form a pod, and in this case, the pod can then be designated through the NINDS in terms of an NINDS designated ALS center, the community level, and incentivize with value-based reimbursement systems for those pods of clinicians, then potentially we can bring care closer to patients at many different geographic areas where we've not been able to penetrate and bring care to ALS patients. So there are many such models. The report is dense. If you're interested in this, please refer to chapter 4 and you can read about all the different models that are discussed there. And the important part about this is because we're bringing in newer centers that includes neurologists that are not ALS experts, it's really important that we have connection to specialized ALS centers at all times whether it is through telehealth or whether it is through complex care needs for patients who can then be referred to hubs or the higher levels of care, a patient never loses their connection to a more complex specialized ALS center at any time, but they can get access to closer centers at all times. The other important aspect of this model is that every center that is designated under this new hub and spokes model will have to participate in research. We don't have data on prevalence. We don't have data on socioeconomic statuses. We don't have a lot of data on population health outcomes. Here, every center would be incentivized to then participate in registry, in natural history studies, potentially even participate as a site for clinical trials as well. So it creates accountability, there's incentivization, and there's also training opportunities for all these centers, particularly for ALS. Now, on the other hand, these are the comprehensive ALS centers, and these are referred to as the hubs in our report. And this is almost similar to the comprehensive cancer centers that are under the umbrella of the NCI designated network. And what we're talking about today are not unimaginable goals. These are already successful models that are in place at a different NIH institute, such as the NCI Institute as well. So if we can adapt and learn from this and actually go beyond ALS and even other neurological disorders, then potentially we could help a number of diseases. So the Comprehensive Cancer Center basically is an all-service center. You can think about these as large academic medical centers that provide the full spectrum of diagnostic and care services and complex care needs, whether it's intensive care or other surgical procedures. But importantly, they have a leadership role in research, not only preclinical translational research to accelerate therapeutic development, but also clinical research, whether it is leading large consortia, clinical trials, and so on and so forth. Another important aspect of these comprehensive ALS centers, very similar again to the comprehensive cancer centers, is the responsibility of these hubs to then bring care closer to people's homes, care and research closer to people's homes. That's the incentive there. And hubs can then engage in innovative models of bringing care closer to people's homes, whether it is in the form of satellite clinics or travel clinics or house call nursing programs, telehealth opportunities, or even partnerships with community-based organizations. And then another important responsibility for these hubs is really about workforce development. Again, there's an incentive here when there's an NINDS designation in terms of accountability and also deliverables for both research and care, but workforce development training, the report lays out a number of different short-term, long-term training fellowships beyond the traditional K award as well. And it's not just for physicians, but also for APPs or nurse practitioners and also other research healthcare workers as well. So that's about the hubs. And then in between is a level, what we call here as the regional centers. And these are spokes they're not as, they don't have all the capabilities as hubs, but they have higher capabilities than a community-based health center. For example, there may be a board-certified EMGer at the center, but they may not have genetic counseling, and so on and so forth. Again, the report actually lays out very clearly in terms of the array of services that these centers can provide, both in terms of care and the responsibilities on the research side in terms of how they can participate in research, again, registries, natural history studies, clinical trials, and potentially even lead some of the qualitative population health outcomes or care delivery type of research at these centers as well. All of these centers are integrated. They're all talking to one another. There's an opportunity for these centers to then be connected to patients at multiple different geographic locations. And if there is a community health center that needs help from any of the higher levels of specialized centers, they can always reach out for second opinions, telehealth, televisits, and so on and so forth. And so the next is about the recommendation 4.2. So if we're trying to bring new systems, new clinics, and expand care, expand access, it's really important for us to be mindful of racial and ethnic equity in ALS care as well as research. We've seen over and over again that more than 90% of participants in ALS research are white Caucasian individuals. It doesn't mean that there's no ALS in other ethnic groups. It's just that they don't have an opportunity and access to some of these research. So it's really important to have those community partnerships at every level. And some of these partnerships could be in the form of steering committees where people with lived experience from a certain community can be a part of this. And some of these can actually be very geographically localized so that we can understand what those nuanced requirements and challenges are in that particular committee so we can tackle those better. And also importantly, collecting data. This is all about evidence-based sort of expansion of infrastructure. And what can we learn on population health outcomes in terms of equity, and also incorporating training modules for staff on implicit bias as well as anti-racism, all a part of the race and ethnic equity recommendation. And this is just a list of all the different types of training programs that potentially could incentivize these different hubs and clinics in the VA as well to expand the workforce. And this is not something that NINDS potentially could do on their own, but this would require a lot of partnerships with nonprofits as well as multiple agencies together. And then recommendation 4.3 is really sort of translating this grand vision into a reality. If there is no incentive, there are no good reimbursement models, this cannot become a reality. And how can we think about these reimbursement models? And there are some recommendations. We're not prescribing any one particular recommendation in this, but there are a few different value-based models. And one that particularly may pertain to this rural remote participation and engagement is about the value-based capitated payment models as well, which have been successful in other disease conditions, whether it is the end-stage renal disease or cancer and so on. And here it is basically a fixed amount of payment for clinics per patient per year. Currently, there are restrictions in terms of the number of visits that a patient can have per year. Medicare has some restrictions on this as well. And then maybe some of those caps can be lifted from this. And then there are delays every time a patient needs to be seen by another specialist, pulmonologist, or other specialist. You have to provide a referral, wait for the prior authorization, creates delays, and all of those caps will be removed in this model. And so there are value-based payments as well as standard fee for service payments where you can actually incorporate adjusted payments for certain key quality metrics in terms of access in rural areas, low socioeconomic status, and underrepresented or marginalized communities as such. There's already a Medicare Act that is being considered. This is mostly in terms of a facility-based fixed payment for multidisciplinary care. And this is a step up from what is currently being discussed in terms of a bill as well. So I'll just sort of end my talk by saying that this is an idea of really sort of lifting all boats, not just for ALS, but multiple neurodegenerative diseases that have the same pain points and could potentially leverage the same common system at the grassroots level and bring care closer to patients' homes, as well as research. So thank you so much.
Hi, I'm really pleased to be here today and to share with all of you the research that we've done in American Indians. I'm Astrid Suki Dicey. I work at Huntington Medical Research Institutes, but a lot of this work was done at Washington State University and University of Washington, and in partnership with communities around the United States. First, I like to talk or start my talks with a brief land acknowledgement of the Native peoples who first inhabited these lands and took care of them and stewarded these lands since time immemorial. Second, I also like to start with a quick self-introduction of who I am and to place myself in the context of the work that I do. I am a research scientist. My interest is in health disparities and health justice in neurological diseases. I focus on Alzheimer's and vascular dementias. My heritage personally is English and Slavic. I am not a Native person, and I am the MPI of the studies that I'll be talking about. So just a little bit of terminology, and I'll show a map also of the peoples that I'm describing. American Indian, Native American, Alaska Native, Indigenous people, these are all accepted terms. These are collective terms for people tracing ancestry from the original indigenous peoples residing across the North American continent. The preferences of which terms are acceptable differ broadly by individual, by tribes, by communities. The general preference is to use specific tribal names when possible, but when that's not possible, American Indian is the preferred term by most indigenous representing groups and is the most common term for national groups. So American Indian and Alaska Native peoples across the United States, this is based on the most recent census, number about 10 million. Large majority live in urban areas, but although the proportions and estimates of the numbers do differ somewhat, a large proportion also live below the federal poverty line or have limited access to socioeconomic resources. And there are more than 570 federally recognized tribes, and these are sovereign nations with independent treaties with the federal government. And I know most of this is probably very familiar to everyone in this room, but I like to introduce it just so that we're all on the same page. The study design for the study that I have been MPI of and that I'll use to describe some of the successes that we have had in working with American Indian peoples and doing research in these communities is the Strong Heart study. And it's a sub-study of that long-standing cohort that's been ongoing for more than 35 years now. It's a community-based or population-based cohort study based in the Dakotas, in Oklahoma, and in Arizona. I'm sorry, my ear hasn't popped since yesterday and I'm hearing an echo inside. So I apologize if I keep yawning. We use 3 different regional field centers, and the original study partnered with 13 different tribes, and there are 11 tribes that are represented in the ongoing neurology cohort. And in that cohort, we conducted magnetic resonance imaging, cognitive testing. We did a comprehensive clinical and medical history exam, risk behaviors, and adjudicated cognitive status. So we have a rich data set of cognitive and related data on these individuals. We had 818 participate at our first exam starting in 2010, and then 400 were able to return for our follow-up about 6.5, 7 years later. So some of the considerations to doing this research in Native communities. I mentioned that these are sovereign nations. Tribal sovereignty means that they have rights to self-governance, which is explicitly recognized by the US Constitution. And this means that they have nation-to-nation diplomacy engagements and agreements with the federal government and are autonomous against encroachment by that government and by states. And so they can make decisions on their property, on citizens, including participation in research for collective participation, and have to be involved in research done on their lands and with their peoples when that engagement is done on a tribal basis. They also have rights to data. So they have, there's a data ownership and data sovereignty consideration that is important. And these rights and the access agreements do differ by tribe based on the tribal laws. But usually the data ownership is retained at the tribal level. And so it's not owned by the researchers. It's not owned or available for open access, which is, I know, a new consideration for NIH research. And so this is a key consideration when conducting research with tribes and setting up tribal agreements. I mentioned that data can be withdrawn by the tribe or by the individual, as is typical for research. And so this is a new level or an additional level of ethical consideration in autonomy and rights to participation. I noticed that Dr. Quarles, of course, mentioned CBPR and that we did have conversations about that. This was a key tenet of the research that we did in these communities, and it's an important concept in conducting research with tribes and other communities and rural and minoritized groups. As she mentioned, it's an equitable approach to community engaged research. In our instance, we approached the communities and collaborated with them in all aspects of the research, from assessing the issues of interest to them, from selecting the methods used to evaluate the conditions of interest, to conducting the actual assessments, including hiring community members to evaluate and assess the conditions and to conduct the community testing. Interpreting the data involves the community advisory board and community members. And then, of course, designing solutions. This is not part explicitly of the study that I'm mentioning, but then going back to them, designing solutions and evaluating outcomes for interventions and prevention-based programs. We partner with community-based organizations. I mentioned the field staff and advisory group, and this is meant not only to improve the research capacity, but also to sustain and develop community-based staff, develop viable career paths and collective efforts, to support community-based investigators and scientists, and to build on those ability of community members to participate in and develop research from the ground up. We developed the community presence that has been ongoing for more than 35 years, and participate in community events, create community events, and develop this collective culture that builds trust. And it's based in a listen, not talk kind of model. We often, try to focus on more listening and less talking. So it's funny to me to be up here talking, because this is the reverse of what I'm used to doing. But all of this is to say that essentially it's about relationship building with the community, the tribe, or the group of interest. And so this would, of course, be generalizable, not just to American Indian or Alaska Native or other indigenous groups, but other minoritized rural populations that may be underrepresented. In our instance, we had complex ethical reviews. This is something that I think may be overwhelming to people not used to doing community-based and especially tribal research. We had more than 10 institutional reviews for this study. I think at last count, it was around 12. It depends a little bit on how many academic institutions are participating. But we have research review boards and tribal councils for each tribe that we work with, as well as each IRBs for each individual academic institution, as well as Indian Health Service IRBs for each region that we're working in. And not only are there many of them, but they often won't review until after the funding is received. And so the NIH requirement that we provide the IRB number or the IRB approval at funding at NOA is often not possible. And additionally, many of them won't review except in a sequential manner. And so they won't review simultaneously, but rather will only review once the other guy has already approved. And so you often have to do it in a kind of chain of approvals. And so it can take quite a lot of time. We often allocate about a year to do all of these reviews for this particular study, but it can take quite a bit of time. And so it helps to be prepared and have that all listed out ahead of time. Additionally, the ethical reviews are important throughout the life of the research program. It's not just at the beginning of the research, but it's ongoing. Of course, everyone is probably used to doing IRB reviews on an annual basis with their own institution, but this is not just the before and during, but also after the dissemination component. The tribal councils and RRBs like to review and are allowed to and must review the dissemination products, whether presentations or papers, after they have been written. They have the right to request edits or reject those dissemination products. They also like to have ongoing review. Some of the groups have ongoing review, even just to enable the continued use of their data during the secondary data analysis phase. Some of the special considerations that we faced in the data collection component: participant hesitation. I think you heard a little bit about participants being hesitant to participate in research. This can be alleviated by involving staff community members, like a familiar face, involving community navigators to assist participants and be with them throughout the process of conducting research. Considering the burden on participants and alleviating not just the length or amount of research that's conducted, but considering the support for costs incurred, the distances that they have to travel. We enable coordinators to drive participants. Some of our participants had to travel 4 to 5 hours each way just to attend the MRI visits at 2 different visits. And so that was quite a significant burden. And this is for people that may not even have access to their own car. The incentive structures are therefore also often higher than for general population studies and may be significant. And so that must be considered in budgeting. The psychological impact is important. Minimizing office-based procedures, presenting tests as puzzles because of some of the educational and medical-based anxieties and traumas that may be faced by some of these communities. It's important to consider some of the kind of mundane activities that may be faced by the general population may not be considered as such by minoritized groups. And so designing the examination procedures with feedback from staff and the community advisory group can be very helpful. considering clinical supports, like providing a basket with reading glasses, hearing aids, because many participants may not even have access to basic medical care and support, and access to even these basic support materials for things like short myopia or hearing loss. And then, of course, sociocultural perspectives. I have an example for one of our cognitive tests that the instructions require an interviewer correcting or the administrator correcting the person taking the test, but that is a cultural no-no, an absolute taboo in communities. You don't correct your elders. And so these tests are often invalid, at least as compared to the general population in the standardized testing methods, and so have to be adapted or at least contextually considered when evaluating the cognitive test scores. So I think that Dr. Benson showed a similar diagram, maybe a better, more complex diagram than this, but this is just to say that social disparities are health disparities. Many of these considerations do lead to measurable health changes and are important considerations in not only designing studies, but in evaluating the conditions that can lead to health outcomes, and especially in neurodegenerative diseases and vascular dementias. And some of these did contribute to our conceptual diagram that has helped us in structuring this study, especially in measuring and evaluating cognition and dementia in this population. Some of the direct effects, which we're really interested in on cognitive test performance, can be confounded or biased or even just precision adjusted by many of these complex effects on cognitive function and validity in cognitive testing, some of which are shown in blue, but there's probably many more latent and measurable effects that we have to consider. And these can include things like social disadvantage, adverse childhood experiences, including in education, low quality and quantity of education, the lived bilingual experience. Many of these elders, more than a third, are significantly bilingual, more than a half are at least somewhat bilingual, and that can influence not just cognitive testing, but also lived experience and cognition. I mentioned socioeconomic health or status, and then of course, psychological health and traumas. And so we have to consider these confounding and often indirect effects in cognitive test performance, as well as cognitive functioning. And so with that, I just want to acknowledge all of the, especially the study participants, their communities, and the field staff that have contributed to this research. This is a huge research effort that I mentioned has been going on more than 35 years. I, as a researcher, am a major beneficiary of that and their strong partnerships with the communities. Our participants and our community advisory board are very proud to be a part of this research, and I'm very lucky to be a part of that research process. And so our field centers are a big part of that in developing those relationships and partnering with our tribal members, and of course, my collaborators and the funding from the National Institutes of Health.
Wow. Really excellent panel discussion. I'm going to ask people from the audience, if you have questions, to please start to make your way towards the microphone. And we also are monitoring the chat, so we want this to be balanced. So I'm going to ask if there's a question.
We have two questions in the chat, Babu. The first is, are ALS patients asked to donate their brains as a part of the MDC model?
Question about tissue. Great question about tissue donation in ALS. Is that a part of the MDC model? We haven't spelled out in terms of what biofluid samples or tissue, but all of that would become a part of that research pillar within the MDC, the hub and spokes model.
Thank you so much. We have one more question for you particularly. So asked by Robert Bone. In many rural areas already have shortages of care practitioners for even basic health needs. The community center hub idea is great, but how practical is it to bring can you hear me? A group of specialists together to a location that is close enough to benefit rural residents. What mileage radius is considered for a community center?
These are really important and great questions. And, I don't have all the answers in terms of specifics of mileage and distance. But all I can say is that there are such models already existing for end-stage renal disease and whether if you go into the CMMI in terms of the integrated network pods. And I think there's a lot for us to learn from. This is the start of the conversation. And from here, we'll have to do some deep dives into the health economics of this, and then into the practical aspects of where these centers will be located, and what the space is, mileage radius, and what's the need and demand in that particular community. All of these things would have to then be ironed out. And this is really the start. It's a roadmap and a framework to think about.
Thank you. And continue to put your questions online as well.
Hi, I'm Phyllis Foxworth with the Huntington's Disease Society of America. And this question is also about the pod model, which I think can be an excellent solution. But my question is, for example, HDSA has over 50 centers of excellence that are co-located in sites, primarily, in urban areas, co-located with sites such as AOS, multidisciplinary clinics. And so we have in the urban model, these multidisciplinary clinics that are co-located and are providing disease-specific care. Is there value in research to see what is the degradation, if any, in the quality of care if you were to collapse those in those co-located sites to see if you can effectively move out a hub model without degradation of quality of care? Because my concern is otherwise we're just continuing the equity issue in those rural areas.
That's a very interesting thought and a great thought. And I don't, the committee did not deliberate on whether we should collapse the existing models. Our committee basically deliberated on what can we build on current existing models, fortify what is already existing, and then sort of bring in new players to bridge those gaps. I don't know if we would be able to collapse a co-located Huntington's clinic or ALS clinic. I think there's a role for these hubs to play as specialized centers, but also be a resource for those spokes in rural areas. But there, think about really merging and bringing together common expertise that can then reach out to those specialized Huntington clinics or ALS clinics for support and sustainability and growth as such. But great thought. Thank you for that question.
Hi, Dr. Babu. Sonia Elling with IMALS. So my question's a little bit building on that, and you touched it at the very end, is did the committee, when asked me to put it together, and we followed it and testified at some point and were involved in it, but curious, because obviously funding, right? We heard from Dr. Horschitz earlier, funding is an issue across the board, and depending on what happens in the election in the fall, it's going to continue being a problem as we have the fiscal constraints. So looking to how to make these multidisciplinary clinics and hubs and centers really more neurodegenerative, because that way then you're not seeing all of the disease groups and all of us having to appeal against each other, which I hate to say it, but it becomes like at a point when we're all going up to Capitol Hill and we're lobbying for the funding for whether it be the ALS clinics or you're going to bring in the Parkinson's or Alzheimer's. So wondering if there was a conversation, because if we start moving forward with some of those recommendations and making the effort on the clinics specific to ALS, I worry if we're missing an opportunity to use our collective strength of everybody in this room and figure out how to work together to build on, just like you kind of touched there at the end, the models, and if that really was a big part of it, and if CMMI is open to that as well, to do maybe a demo somewhere, and if we should all go see Liz and start having conversations. So thank you.
Thank you for that question. It sounds to me like there are two parts to that question. One is probably really for Dr. Koroshetz, who I'm seeing is walking away. And the other is about.
So I'm thinking more from the Medicare perspective, right? And that's where I'm at with funding, but he just highlighted the challenges we have.
But it's a really wonderful thought to think about an umbrella of neurodegenerative hub and spokes. Going back to the committee, our committee was entrusted with the task that was very specific for ALS, and we had to stick to the statement of tasks. But again, this is a roadmap, a framework, and what we do with this model and how we build and grow this in different directions is really up to all of us as the neurology committee. And if we have the right reimbursement models, and even the report basically says that it's not all about NIH needing to support this. There are different players, and we call out on different players, CMS, as well as private insurers. And there's a very specific role also for nonprofits in terms of supporting this model where insurance doesn't meet the requirements of certain care needs or research needs. And then the designation is sort of that incentive for this model to sort of grow. And if there is an opportunity to make this a broad neurodegenerative hub and spokes, and that would be fantastic. I would think that'll be probably a question and something to discuss with Dr. Korsh's team or an idea.
So I went through what you're going through for about 10 years in the stroke field. And so there was a treatment that NINDS, the clinical trial, it completely changed how stroke is cared for. So it really points to the value of a treatment changes everything. Now, we didn't know what we were doing, but what actually happened was that what we ended up doing was taking advantage of the competition of the hospitals and the healthcare systems. So we spent a lot of time trying to educate people how valuable this was. It went nowhere. What we did was we developed some guidelines as a group, and NIH is part of it, but the American Heart Association was a big player. And then the trick was that the American Heart Association went to the Joint Commission. Joint Commission accredits hospitals, but they also accredit specialty care. That is separate from what they do for accrediting hospitals. It's a for-profit wing of JACO. Once that happened, then the ball started moving, because once JACO accredited a stroke center, then the hospital down the street needed to be a stroke center. And so it just went, and it was probably the biggest success that JACO has ever seen. So that was, pre-NIH experience working with the system we have, which is a competitive, financially motivated system. But you can, if you follow that stroke model, which we have primary centers, it can work. But you just have to insert the right incentives to get that ball rolling. And but we still have problems with equity. Just had, as Richard ran a program on, health equity for acute stroke care. It's still far from perfect, but before that treatment, people with stroke were put in the hospital and sent to rehab, and no one took care of them. So it's just a great example of how a treatment can change the whole system of care. That might be happening in Alzheimer's now. So that might be the beginning of something.
Thank you, Dr. Korshitz. And I think that goes back also to that integrated hub and spokes for neurodegenerative diseases broadly than a certain disease specific, sort of like the NCI model. It's broad cancer as opposed to a certain type of cancer too.
So I'm going to ask Penny just a moment. Are there questions online, particularly for our other two panelists? I want to make sure.
One for Dr. Suchi Dicey. Would it So Robert Bone asked, would it all be practical to consider a mobile multidisciplinary care team that could travel with equipment to various regional locations?
I almost think that's a question for Dr. Babu, but I do think that mobile care teams can be really effective, especially at least in research, because you can reach populations that don't otherwise have access to specialty care clinics where research is conducted. You know, I mentioned that some of our participants had to travel 4 to 5 hours each way just to reach the closest radiology center, which had itself limited functionality, and no ability to do PET or fMRI, just structural MRI. And so, you know, having access to neurologists, neuropsychologists, imaging, I think could be really effective to reaching some of those more difficult to connect populations. Yes, but I think for care, they'd have to come pretty regularly, you know, maybe on a loop or something, because people have to be able to receive repeated care. So, you know, the vision beyond that, I think, would be for you to answer, but
There is, you know, there are so many different ways to think about innovative care models to bring care and research closer to patients' homes, whether it's decentralized trials or mobile satellite clinics is being piloted as part of some of the ALS centers, especially at the UCSF. Dr. Kathy Loman-Hurth is actually piloting something like this, where travel clinics, multidisciplinary teams go to different areas of rural California once, I think monthly 3 months or 4 months to provide care. And then there's also the house call nursing program that Mass General has piloted for Massachusetts, where nurse practitioner and nurse will have combined visits with a nonprofit organization like Compassion Care ALS in the homes of ALS patients across a certain zip code. So there are different ways of then thinking about innovative care models like that. Thank you for the question.
So hearing the great work that all of you are doing, one thing that kind of came to my mind of what your talks illustrated was differing community perspectives on secondary use of data and samples. So you presented on a lot of Native American populations where they own their own data. And frankly, I admire the work that, I mean, the amount of years of time that it will be taking to do that sequential IRB review that you're describing, when then one IRB disagrees with another. And we've heard of IRBs, like I've seen the Alzheimer's Association led a wonderful initiative years ago that I was a part of, that they heard directly from people living with early stages of Alzheimer's disease and talked about secondary use of data and samples and how important it was to somebody that if they participate in research, they're doing it to make the most progress for the field possible, and that it was an insult to them and their participation that it wasn't being maximized. But then there's also communities that have been put at risk from research, particularly in the past, but that they have history that they're not trusting research in the same way. Or I think I've heard a wonderful example from the Native American community where research that was intended for one thing was then the data and samples were used for something totally different that then was culturally not acceptable to that community. So I feel like there's this inherent tension, particularly as we try to make data more inclusive, and even on the medical care side, where a lot of medical care databases are being used in research, often without, maybe it's in the fine print, but most patients have no idea how many uses are going to their data, including biopharma buying huge data sets, right? I'd love to just hear some reflections from you guys, as we want research to be more respectful of different cultural populations and inclusive, and moving forward to help those communities as well, but then they have different perspectives on these things.
I can start. A couple of years ago, gosh, maybe nearly 10 years ago, we were doing a genetics study looking at potential genetic causes for severe hypertension in Blacks. And we heard, and it seems to be generally believed, that Blacks won't participate in, or are reluctant to participate in research and genetic research. And so as part of the LC team, we went out and talked to community members to get a sense of why, what is the barrier, why wouldn't you? But it really is about that trusted voice. Who's asking? And it goes back to the history of that exploitation of that community. Communities have long memories. And so it really is about who's asking the question and who's willing to go out and have that discussion. And also educate the community about what it means to consent to this work. And part of the concern about particularly the genetic research was we cannot, it was, where is our data going? Who are you willing to share the data with? And interestingly, I wonder if we were to redo it now, what they would say, but they were fine with sharing the data with the government, but they weren't fine with sharing it with pharma or for-profit entities. But it really came down to the participants having an altruistic mindset and wanting things to be better for their future generations. But it's a matter of who's asking and how transparent we are when we're approaching the community.
Yeah, I would definitely echo those sentiments. I think the tribe you're speaking about is the Havasupai tribe, the genetic example. Yeah, that's a great example of research gone wrong, where they didn't even ask to change the research question. And I think, you know, what you're talking about, it's about trust. And so I think that they're oftentimes quite open to asking novel research questions and using the data for secondary purposes. Generally, in my experience, the consent is important. And so it needs to be related to the original consent. That's, you know, the ethical principles of research. But, you know, assuming that that is fulfilled, the tribes are generally very open to entertaining novel research questions. It's just a matter of asking to do that, you know, and getting the permission. And so basically being transparent about what you're doing with the data at all stages. And, you know, I agree with you that there is this kind of inherent conflict between, you know, tribal governance and tribal data ownership and individual autonomy to participate in research. And I think it's a really interesting ethical area. And I think ethics is a complex field and I hope to see that develop, but, you know, I think.
It just feels like this inherent tension because we see the ethics of maximal sharing, but if you really are sharing broadly, you cannot guarantee to the people who are originally participating exactly what use their data and samples will go to. And you can have a trusted committee that tries to steward it, but then how much are you putting it out there? Here's a database to use, and how much are you really vetting every single one? And if so, who gets to be that gatekeeper? And then, I mean, in the neurodegenerative space, people die. So then how, or their capacity to consent changes. So then you physically can't go back to reconsent. So then it's just a tough space.
And I was just going to add that, you know, one of the questions we asked is in terms of going back and asking new questions with their data, how they felt about that. And one of the concerns was what would be the topic of research. Are people going to go and honestly, their response was, are they going to go and then say that Blacks have a genetic predisposition for violence or something like that, when this was a cardiovascular research study? And wanting to kind of control that narrative and where the research questions go with their data.
But so I represent AFTD and our patients are in ALS clinics, they're in Alzheimer's clinics, they're in Parkinson's, and they might be in mental health clinics. And so if, for example, there's a study of trying to, like, when there's consent saying, well, the research is going to be specific to ALS, or the research is going to be specific to Alzheimer's. And then suddenly you have these related diseases. And then it's shut out. And then you have to regather samples and data that might already be there. And you also get roadblocks of understanding how the different diseases connect with each other and how much is comorbid and how much is the one affecting the trajectory of the other. But then it's really hard to draw these lines that can be
That's the
clear.
challenge. I think that really is a challenge in terms of research that can help and not harm the community. And I'm talking about the community as a unit of identity that is separate from the individual. And when we think about minority communities, they are often lumped up when it's something negative. And so when it's that, it is a challenging ethical question of how to be able to use this data collectively to answer a number of questions, but also not use it in a harmful way. Yeah.
I think that's where involving the community and trying to answer those I mean, there may not be an answer, but involving them in that conversation is so important, you know, just like.
Yeah, well, thank you. Yeah, it's been a great discussion. We're standing now between lunch, I think, for a lot of people. And I don't know if you.
Yeah, Joe, really, really great discussion, a lot of hard questions. You know, sometimes you can't always get what you want, but you try sometime, you get what you need, and I think that's the lessons we have to keep pushing forward to get what we need. So see everybody back here at 1:30, I think, yeah, and so there are a lot of restaurants where you can spend a lot of money a block away, Pike and Rose. And I think we still might have some coffee here if you can just get by on caffeine. I'll see you at 1:30. Thanks, everybody.